Thank you very much. First, excuse me if my voice is not very clear because I had some cold within the last day, so I hope it will last well until the end of the presentation. Second, thank you very much to my friends from Brussels for this invitation. You know that it's always a pleasure for me to be here. It's a little bit my house, we can say so. So I feel very well every time I come, so thanks again. And third, thank you for giving me this talk, because I think that it's a little bit philosophical talk, and I like philosophy, as you know. So I will do, okay, we will discuss after. So if we come back to the last, not the last guidelines, but the last but one guidelines, those from 2020. When you read them, you see that it was a sentence saying that in persistent and long-standing persistent AFib, more extensive ablations has been advocated. So this may include linear lesions, isolation of the left appendage, etc., etc. Okay. So, because I am quite a basic guy, I was thinking that maybe it was the right time to promote extra PV lesions. Why? Because we know that PV isolation only for the persistent AFib seems not to be enough. And today we have new tools like high power short duration, PFA. Jean-Baptiste was explaining the benefit of PFA, and no doubt I'm completely with you, Jean-Baptiste. Marshall, why not? And these are more efficient to provide transmural and durable lesions. We saw that in the previous talk. But last month in London, we had the guidelines, the new guidelines, and they said, okay, you can read the sentence, it's more or less the same sentence than in 2020, so back to the future. Large variability in ablation strategy and techniques exist for patients with persistent AF, yes, or after first failed catheter ablation. The optimal catheter ablation strategy and techniques, however, are unknown. Okay, little bit disappointing, but... And the consensus to which I participated is saying the same in a different way. You can see everything, rotor ablation, Marshall, isolation of posterior wall, area of uncertainty, which is fair because, to be honest with you, today we don't have big trials, randomized trials, showing that there is an advantage to do that. So I can say that I agree. This is area of uncertainty. And another point that we completely agree with Jean-Baptiste is that we have to do PV isolation in all patients, paroxysmal and persistent patients, AFib patients. Why? Because PV isolation is not only PV isolation. PV isolation is ablation of fragmented potentials at the antrum of the veins, ganglia, substrates that are in this area of the antrum. We are performing more than PV isolation. It's more than that. And in fact, when you're looking, and in the previous talk we had the example of cryo, a posterior wall after cryoablation, it looks like that. When you're doing a high-density voltage map, you see that all in red has been ablated. So while you are performing PV isolation with a 28 mm balloon, only PV isolation, you are performing ablation of a big part of the posterior wall. There is no doubt about that. And it has been demonstrated not by us, but by other people like Kennisberg, but in other papers also. I think that Brussels also did a paper on that, that when you're providing large PV isolation with a cryoballoon, you are providing also 2/3 ablation of the posterior wall only by the PV isolation with a big balloon. And this is something that we need to remember. It's important. And this is the reason why, or one of the reasons why we decided to perform long time ago in 2018. In fact, it was much before that because we did the trial, so and then follow up. So we started in 2014, 2015. And we were observing the outcomes, the follow-up of patients having short persistent atrial fibrillation, so less than 1 year, in which we perform only PV isolation. And after the follow-up of 1 year, we saw that in these patients, we had more or less 60%, a little bit more, 60.7% of success rate of sinus rhythm at 1 year only with PV isolation of these patients. But 60% means that it's not enough, and we need something else. We cannot get satisfied with 60% of success rate. You agree with me that it's not enough. So what? I like this slide. I used this slide when I was young, so not too long ago. And this slide, I like it because, look, this is a kind of symbolic representation of what is atrial fibrillation, and particularly in the posterior wall. What is this? This is microentry, this is rotors, this is PVs, this is Marshall, this is ganglia. In a word, this is a mess. And in fact, atrial fibrillation is a mess when it's persistent. When it's paroxysmal, it's more organized. Maybe we know where we can trigger the right points. But persistent, you don't have two patients that are equal. All patients are different. And even from 1 second to another second, who knows if the circuits are the same? We don't know. So we have to be honest with this. And this is the reason why we have re-entry not only in atrial fibrillation, but also in what we are doing since 1998. This is the reason why we are at the same point today with the guidelines. We don't know. And in fact, we are turning around since 98 till today with this problem of atrial fibrillation. And here I come to the philosophy of my presentation. Atrial fibrillation is like religion. You have people that believe in a God and other people that believe in another God. Maybe they are the same, but they say they are different. Okay, you have people that believe in trigger. I believe in trigger. I was believer in trigger when I started ablating persistent atrial fibrillation. We are looking for reentrant circuits, rotors. We are doing very complicated maps. We believed in triggers, in my team and myself. And you have people that believe in substrate. And today, to be honest with you, I believe more in substrate. So I have changed a little bit my religion. But at the end, you have a so big overlap between trigger and substrate that in fact, maybe it's the same God, who knows. Ablation strategy, this is a very old slide. This slide is from Michel Aissaguer. At that time, he allowed me to use it, so I still use it today, and so more than 25 years after. And you can see here also that you have a difference of the ablation strategy when you have a paroxysmal AFib and a long persistent AFib, and in between persistent, short persistent AFib. And you see that the substrate and the triggers, pulmonary veins and the left atrium, are a little bit more important in paroxysmal, and the substrate is more important in long persistent. But in fact, here again, we have an overlap. It's not all substrate, not all triggers. And the surgeon, and I see Marc, bonjour. The surgeons, they are the most clever of us. Why? Because they say, okay, we will perform lines in order to create a maze, in order to treat these patients having, what I was saying before, a kind of mess, particularly in the posterior wall. And then, because sometimes we think that the surgeons are not stupid, like me, I think they are not, and we follow them. And what we are doing now is also performing isolation of the posterior wall with ablation. And it's not very difficult, honestly. When you are doing the isolation of the antrum, both sides, to perform two lines, one on the roof and one in the posterior part of the atrium, honestly, it's not the most difficult to do. So we are doing that. However, you have this important paper from the team of Sanders and Kalman that was showing that this is the Kaplan trial. When you randomize patients performing only PV isolation and patients performing PV isolation plus posterior wall, you have 338 patients randomized. This is a very serious trial, very important, and I believe it's important to know this trial, Kaplan trial. You see what? You see that during the 1 year follow-up, no difference. This is very disappointing. However, let me tell you something. Don't forget that this trial was not cryo, was not PFA, was RF. And are you sure that with RF, when you're performing the lines point by point, which is easy, it's true that it's easy, but it's easy also to leave gaps. So this is maybe something that in my mind could be at least a point that we should think about. And this nice trial that nobody speaks about, but I really like this trial since very long time. And Carlo knows, because when we are doing together the courses, I always have these slides, is about this trial from Malte Kunis that perform 2 groups. It's not randomized. To be honest, it's a small effective, it's a small cohort, it's not randomized, but it's very interesting. Look, they compare a group performing persistent ablation with radiofrequency and a group doing persistent AFib ablation with cryo. In these groups, they did half of the patients with a roof line in both groups, RF and cryo. So that means that in 100 patients in the RF group, you have 50 more or less patients having a roof line with RF. And in the group of cryo, you have 50%, so 50 patients more or less, having a line with a cryo balloon. And with a cryo balloon, it's easy to perform a line with a cryo balloon. Very interesting. Look, the outcomes of the patients after 3 years, you can see that between the 2 groups, cryo and radiofrequency, there is no difference. So globally, the outcomes are the same. However, when you just take the subgroup with a line on the roof, and you compare the roof done with a cryo balloon with the roof done with a radiofrequency, in this case, you have a very significant difference between the 2 groups. What does it mean? It means that probably a line with a cryo balloon, so with a big tool, is probably more reproducible than with radiofrequency. This is what I interpret. Maybe I'm wrong, but this is what I was thinking about. And this was the reason why I moved to cryo for performing lines at that time. And now, you have this trial, very important trial from Arash Ariana that did this time a randomized trial comparing PVI only with cryo balloon and PVI plus posterior wall ablation. But even more than that, when they did the posterior wall and the PV isolation, they did a high density voltage map. And if it was a gap remaining, they closed the gap systematically with radiofrequency. So this was a very well done trial and a very well done posterior wall isolation. And in this case, the outcome of these patients, so small cohort, again, 50 and 50, if I remember well, yes, 55 and 55, you see that obviously when you are doing the posterior wall, it's a little bit longer, more ablation time, but it's not too much longer. It's more or less 2 hours and 2 hours and a half, more or less, when you are performing the posterior wall in addition. But the outcomes, look, when you're looking here behind or here for AFib recurrence or all arrhythmia recurrences, you have a very significant in favor of posterior wall isolation added to the PV isolation with a cryo balloon and eventually closing the gaps with radiofrequency. And on the right, it's also very interesting. And this is a little bit, this is something that we could discuss because they compare also the patients having a low voltage in the posterior wall. And when the low voltage in the posterior wall was present, you see that the difference between PVI only and PVI plus posterior wall is not significant now. But when this low voltage in the posterior wall is absent, in this case, you have a very significant difference. What does it mean? It means that maybe when you have a posterior wall that is mute, that is not really working, you don't need to do the posterior wall. Seems logical, but then it's a little bit controversial with other papers like the Erase AF and so on. So this is a little, okay, we can discuss further on. What are we doing in Toulouse? In Toulouse, we use some tools. This is, for example, the Volta, which are trying to understand what I was saying before, because at the beginning, remember that we are believers of the God, the God trigger, the trigger God. And we still believe a little bit on it. And we are looking for re-entrance circuits with tools like Volta and other tools. And when we started PFA, we tried to use PFA and Volta in order to try to understand if PFA was interesting in these patients. And we saw that most of the reentrant micro-reentry and dispersion was in the posterior wall, in fact. Look in this patient. All the yellow dots and white dots, most of them are in the posterior part of the left atrium. So we decided to do what? To do a posterior wall isolation with a PFA. And it's very fast and it works very well. And you see that if you come back here, just after a few applications, you see that the organization of the arrhythmia in the coronary sinus, this is before the application and after the application. You see that the arrhythmia is organizing, and then most of the time we can record the sinus rhythm. What does it mean? Okay, we can discuss also about that. So what is our strategy in 2024? And I insist on that because probably, certainly, in 2025, it can be different, or in 2026 will be different. We are moving because obviously I don't say that we have understood what happens. We didn't understand anything, but we are trying to understand. And for the moment, what we are doing in short persistent, we are doing exactly what Jean-Baptiste was saying. We are doing PV isolation plus, in this case, we are adding a roof line, and most of the time with PFA. In all others, we are doing PZ, so more than 6 months in duration or large left atrium. We are doing PV isolation, again, posterior wall isolation, plus or minus mitral isthmus ablation. And this is now we are doing in the PFA era. This has changed our approach since 2021. We moved to this kind of strategy. And we are trying to understand if it's really worth. This is a first paper that we have published using this approach. So the title was Mitral Isthmus in Persistent Atrial Fibrillation, but in fact, it was exactly what I was explaining. We are performing PV isolation here, A, posterior wall isolation, B, and mitral isolation, C. And what you can see is that only 45 patients, no randomization, it was just a feasibility trial. What we can see here is that the total procedure time is less than 1 hour and a half, so it's relatively short until reaching the mitral, because all the patients in this group are at PVI, posterior wall, and mitral, so there's 3 steps for all patients, less than 1 hour and a half, fluoroscopy of 20 minutes, more or less, and acutely, I insist, acutely, PV isolation in 100%, posterior wall isolation in 100%, we checked all patients, and mitral isthmus in 100%, acutely. Follow-up. Follow-up is a little less positive, but okay. Follow-up, we had short follow-up in this paper, or a little bit between 3 and 4 months, and in this, let's say, kind of blanking period, we had already 6% of AFib recurrences, but higher number, 13% of atrial flutter recurrences. Why? Because in fact, what is the main recurrence is on the lines we are performing again. And this is the big problem. And the most recurrences we had were in the mitral isthmus. Nearly 90% of the recurrences of the atrial flutter were mitral flutter. On the other hand, it's not a very bad news because you know that it's mitral, and then you go with a second procedure, this time with a high density voltage map, and you are closing the gap sometimes with a Marshall on the mitral. You have other tools today that are very interesting, in which we are also using this strategy, and we are now trying to understand if with these tools it's more interesting. And this is, for example, the tool from Medtronic with the Affera, the Sphere 9, and we are doing exactly the same. Basically, PV isolation, roof, posterior line, mitral. And now we are in this kind of journey. Just to say, I have finished my talk. But just to say that we have finished in January of this year, 2024, the BTF trial. And in this trial, don't forget that you have a group of persistent atrial fibrillation that were randomized with posterior wall isolation with radiofrequency versus PFA. So we are now doing the follow-up of this patient, and we should have the results of this in a little bit less than 1 year, I think. And we will see if this is interesting. We have participated to this trial, and I think that's okay. It will be interesting to see the results. And my take home, correct strategy, to be honest, remains still unknown. I agree with the guidelines. I don't disagree with the guidelines, of course, no doubt, still unknown. What we are doing for extra PV isolation in short persistent atrial fibrillation, less than 6 months, sometimes 1 year when the left atrium is non-dilated, PV isolation plus roof, that's it. More than 1 year or dilated left atrium, PV isolation plus substrate in this case, posterior wall, sometimes mitral, and very rarely Marshall, very rarely. And when we do a redo of these patients, then this time we switch to high density map and we ablate the gaps. Sometimes we go to scar fibrosis ablation. And I really believe that the new tools that we have today may change the strategy and create, in my opinion, at least for me, new expectations. Thank you very much.